Welcome back to the Deep Dive, where we crack open complex topics and pull out the most fascinating, actionable insights. Today we're diving into something truly foundational, something that impacts every step you take, every jump you make, and how you simply stand upright. We're talking about the incredible engineering of your human lower limb.
It really is a remarkable piece of biological machinery.
Our mission today is to go deep, not just to list facts, but to equip you with a professional-level understanding of this intricate system, much like an elite clinician would approach it.
Exactly. We want you to grasp the connections, the why behind the what.
We've sifted through all the detailed anatomical and clinical information, and we're here to give you the most important nuggets, those aha moments that connect the dots between how your body is built and how it actually moves and works.
Those moments are key, aren't they? When the pieces just click into place.
So how will we accomplish this? We'll journey from the very anchor points that connect your legs to your body, through its distinct regions and vital anatomical crossroads. We'll explore the dual genius of the lower limb, its ability to support your entire body weight with minimal energy, and its power to propel you through space.
Two absolutely fundamental functions: support and movement.
Then, we'll take a meticulous look at the key bones, crucial joints, powerful muscles, intricate nerves, and life-giving vessels that make it all happen. And finally, we'll see how this deep knowledge plays out in real-world clinical cases, revealing why these details are so incredibly critical when things go wrong. Get ready to truly master this understanding.
Let's get started. The grand blueprint, architecture, and conceptual overview of the lower limb.
Okay, let's unpack this right from the start. How is such a powerful limb, one that bears all our weight, even attached to the rest of us? It's not just floating there, is it?
No, definitely not floating. What's truly ingenious here is how robustly your lower limb is anchored. It's directly connected to your axial skeleton, that's your spine and skull, through a specific spot called the sacroiliac joint.
The sacroiliac.
But it's more than just a joint. This connection is dramatically strengthened by a complex web of incredibly strong ligaments that intimately link your pelvic bone to the sacrum, that triangular bone at the base of your spine. Think of it as the ultimate load-bearing foundation for all lower limb function, designed to absorb and distribute immense stress.
So when you junk or lift something heavy, those initial anchoring points are literally taking the brunt of that force.
Precisely. They're meticulously designed to prevent damage to your spine and pelvis. This foundational strength is absolutely key to understanding everything else that follows. It's the starting point.
That makes a lot of sense. Now, if we're trying to master this area, where exactly does the lower limb officially begin? It's more than just a casual boundary line, right?
Yeah.
It seems important to define precisely.
Absolutely. This isn't an arbitrary pencil mark. The lower limb is meticulously separated from the abdomen, back, and perineum by a continuous, distinct anatomical line. And this line isn't just descriptive. It reflects deeper fascial and muscular planes, defining functional regions.
Okay, so it has real functional significance.
Immense significance. Knowing these precise boundaries is absolutely essential for clinicians, for instance, when assessing the true extent of an infection, diagnosing where pain might be originating from, or planning surgical interventions to avoid vital structures. For professionals, recognizing these exact topographical landmarks is fundamental for accurate diagnosis and safe practice. You simply have to know them.
Can you give us a sense of how that line traces out on the body? It sounds quite specific.
Certainly. Imagine a path. It starts from the pubic tubercle, a small bump on your pubic bone, and runs along the inguinal ligament, all the way to a prominent point on your hip bone called the anterior superior iliac spine.
Okay, the ACCs, right?
That's the one, the ACES. And then it traces the top of your hip bone, the iliac crest, to the posterior superior iliac spine at the back. That segment separates the limb from the front and sides of your abdomen. From that posterior superior iliac spine, it follows the side of your sacrum down to the tailbone, your coccyx, separating it from the back muscles. Finally, to complete the circle and separate it from the perineum, the area between your legs, this line joins specific points like the medial margin of the sacrotuberous ligament, the ischial tuberosity, and back to the pubic symphysis.
That's a really detailed map. So thinking of it like different neighborhoods, each with its own character and purpose, how do we break down the lower limb's landscape into manageable regions? That seems like the next logical step.
That analogy works perfectly. The lower limb is systematically divided into 4 main regions, each highly specialized: the gluteal region, the thigh, the leg, and the foot. These aren't just names. They're defined by major joints, underlying bones, and visible landmarks. And each plays a unique role in movement and support.
Give us the highlights of each. What makes each region distinct?
Okay, so the gluteal region is your buttocks area, located posterolaterally, extending from the top of your hip bone, the iliac crest, down to the gluteal fold. Pretty straightforward. Then you have the thigh, which spans from your groin, the inguinal ligament, down to the knee joint. The hip joint itself is tucked right below the middle of that groin line.
Okay.
The leg is simply the segment between your knee joint and your ankle joint, the main shaft of your lower limb. Sometimes people call the whole thing the leg, but anatomically, this is the specific region.
Right. Tibia and fibula territory.
Exactly. And finally, the foot encompasses everything below the ankle. Each of these regions is designed for specific tasks, from the powerful propulsion generated in the thigh to the intricate balance and adaptability of the foot. And this compartmentalization also has profound clinical implications, such as in conditions like compartment syndrome, where localized swelling can dangerously compromise blood flow and nerve function within a confined region. Knowing these regions allows for precise communication and targeted treatment strategies.
Here's where it gets really interesting. These aren't just open spaces. They're like anatomical superhighways and critical tunnels. What are these key transition zones and why are they so important? Any compression or damage in these concentrated areas can have widespread effects, which is something the pros always watch out for.
Precisely. These areas of transition are critical. Think of them as choke points or vital corridors where essential nerves, vessels, and tendons are bundled closely together as they pass between regions. Their concentrated nature makes them particularly vulnerable.
So if something goes wrong in one of these bottlenecks, the impact could be widespread, like a traffic jam.
Exactly, a perfect analogy. For instance, the inguinal ligament acts as a superior gateway, funneling numerous structures from the abdomen into the anterior thigh. Just below it, in the upper thigh, is the femoral triangle. This anteromedial region is absolutely critical because it contains major neurovascular structures, the femoral nerve, artery, and vein, along with important lymphatics.
Right.
Very crowded, very important. Then, behind your knee, you have the popliteal fossa, a distinct diamond-shaped space that serves as a vital conduit for the popliteal artery and vein and the tibial and common fibular nerves. Another critical junction. Finally, on the inner backside of your ankle, we find the tarsal tunnel. This is a series of canals formed by bone and a strong fibrous band called the flexor retinaculum, providing a protected pathway for crucial nerves, vessels, and flexor tendons as they pass into the foot.
So these are areas of both immense importance and immense vulnerability. Understanding them seems non-negotiable for anyone dealing with lower limb issues.
Absolutely, non-negotiable. The vulnerability of these zones, such as the common fibular nerve's superficial course around the neck of the fibula, we'll come back to that, underscores the paramount importance of understanding their precise anatomy. Clinicians must consider these areas when diagnosing and preventing issues like nerve impingement, where a nerve gets pinched, vascular compromise, or compartment syndrome. A thorough understanding here can literally mean the difference between minor discomfort and permanent functional loss for a patient. 2. The lower limb's core mission: support and locomotion.
Think about it. We stand upright, seemingly effortlessly, for hours. How does our lower limb manage that without constant exhaustion, even if you're just waiting in line? It feels like magic sometimes.
It does, doesn't it? But it's truly an engineering marvel designed to be incredibly energy efficient. A primary and a remarkable function of the lower limb is to support your entire body weight while expending minimal energy. This efficiency is achieved through two sophisticated mechanisms: the strategic positioning of your body's center of gravity and the clever locking mechanisms within your major joints.
So it's a bit like balancing a perfectly weighted stack, getting that center of gravity just right.
Exactly. When you stand erect, your body's center of gravity is precisely positioned just in front of your S2 vertebra in the pelvis. A vertical line drop from this point falls slightly behind your hip joints, critically in front of both your knee and ankle joints, and lands directly over the circular support base formed by your feet. This precise alignment inherently encourages your knee and hip joints to remain in an extended weight-bearing position. Gravity actually helps keep you straight.
And the locking mechanism you mentioned, how does that contribute?
That's the genius part. The unique organization of ligaments at both your hip and knee joints, combined with the specific shapes of their articular surfaces, especially at the knee, enables these joints to lock into an extended position when standing. This locking significantly reduces the muscular energy you'd otherwise need to maintain an upright stance.
So muscles can relax more.
Precisely. It transforms a potentially dynamic and energy-intensive posture into a relatively static and energy-efficient one, allowing you to stand for prolonged periods without constant, fatiguing muscular effort. This is incredibly important in understanding musculoskeletal disorders that affect joint stability. Any disruption to this locking mechanism means muscles have to work much harder.
From a leisurely stroll to a full-out sprint, our lower limbs are master movers. But there's more to it than just bending and straightening. There's a whole symphony of movement involved. What are the key elements of this locomotion? How do we move so smoothly?
Indeed, it's a beautifully choreographed symphony. The second major function of the lower limbs is to move your body through space. This isn't just random motion, it involves the seamless integration of movements at all joints throughout the lower limb, precisely positioning the foot on the ground, and then efficiently moving the body over that foot. During walking, your lower limbs employ various anatomical strategies to minimize fluctuations in your body's center of gravity. This significantly reduces the energy required for locomotion and results in a remarkably smooth, rhythmic gait, rather than a jarring up and down or side-to-side motion.
So it's about making movement as smooth and effortless as possible, minimizing wasted energy.
Absolutely. There are several key determinants of gait smoothness. For instance, as one leg swings forward, your pelvis rotates in the transverse plane on that side. This subtle twist effectively lengthens the limb, minimizing the overall drop in your body's center of gravity.
Okay, a little twist helps.
Then, as weight is transferred onto a fully extended limb, a slight knee flexion occurs. This effectively shortens the limb, minimizing an unwanted rise in the center of gravity during mid-stance. Also, a controlled pelvic tilt, a slight downward drop on the swinging limb side, further minimizes the rise in the center of gravity, maintaining a smoother trajectory.
And what about side-to-side movement? We don't really waddle much when we walk normally.
Right. To minimize lateral shifting, your knees move slightly inward towards the midline, involving subtle hip adduction. This promotes a more stable and linear path. And finally, the hip abductor muscles on your weight-bearing, or stance side, actively abduct to limit pelvic drop on the opposite, swinging side, again contributing to lateral stability. This sophisticated and coordinated interplay is why detailed gait analysis is such an invaluable tool in clinical practice. Even subtle changes in any of these determinants can indicate an underlying neurological or musculoskeletal issue, profoundly impacting a patient's energy efficiency, stability, and increasing their risk of falls. It's not just about moving, but moving optimally and symmetrically. Experts look for these subtle deviations. 3. The skeletal framework, bones and joints of the lower limb. Moving from the overall blueprint to the individual structures, let's start with the foundation, the pelvic girdle. Each pelvic bone is a robust structure, formed by the intricate fusion of 3 bones, the ilium, ischium, and pubis, which occurs during childhood. This complex bone articulates with the sacrum and is strongly anchored by crucial ligaments like the sacrotuberous and sacrospinous ligaments, connecting it firmly to the sacrum and coccyx.
That fusion during childhood is fascinating. How does this detailed architecture support so much of our movement and stability? It's more than just a simple bone, right? It seems incredibly complex.
It's a testament to evolutionary design, providing both immense strength and multiple precise attachment points for powerful muscles. Let's zoom in on a few key areas. The ilium is the broad, flared part you feel at the top of your hip. You can easily palpate the iliac crest, which ends at the front with the anterior superior iliac spine, and at the back with the posterior superior iliac spine. These aren't just bumps, they're critical landmarks and muscle attachment sites.
Right. You mentioned those for the boundary line.
Exactly. And the gluteal surface of the ilium has these subtle curved lines, the gluteal lines, which mark where your powerful gluteal muscles attach, enabling movements like leg abduction. Then there's the ischium, the posterior-inferior part, essentially what you sit on. Its most prominent feature is the ischial tuberosity, that hard, bony prominence at the bottom of your buttocks.
The sitting bone.
That's the one. This is an incredibly important anchor point for your powerful hamstring muscles, the ones that let you run and jump. Understanding this helps us see why it's a common spot for injuries, especially in athletes who put immense strain on it. Finally, the pubis forms the front of the pelvis, featuring the palpable pubic tubercle and the pubic symphysis. The ischipubic ramus, formed by both the ischium and pubis, provides extensive attachment for the muscles of the inner thigh that bring your legs together. This intricate bony architecture isn't just for muscle attachment. It's a testament to the immense and complex forces acting on the pelvis during weight-bearing, locomotion, and even simple movements like sitting. For an elite professional, this level of detail is indispensable for understanding both normal function and pathological conditions.
The hip joint is often called a ball and socket for a reason. But it's a pretty special one, designed to handle immense loads while allowing incredible movement. It's a workhorse of our body. What makes it so robust and versatile?
It is indeed a remarkable workhorse. It's a multi-axial ball and socket synovial joint, where the spherical head of the femur, your thigh bone, fits deeply into the cup-shaped acetabulum of your pelvic bone. Its design inherently prioritizes stability and exceptional weight bearing, even at the cost of some extreme, uncontrolled mobility. Stability is paramount here.
So it's designed to be a really deep, secure fit compared to, say, the shoulder.
Much deeper, yes, exactly.
Right.
The acetabulum almost entirely encompasses the femoral head, contributing significantly to its inherent stability. The deepest part of the acetabulum, the lunate surface, is covered in smooth cartilage, and it's broadest at the top, reflecting where the primary weight is borne. Beyond the bone, several crucial reinforcing structures provide its exceptional stability. The acetabular labrum is a fibrocartilaginous collar that subtly deepens the rim of the acetabulum, enhancing its grip on the femoral head like a suction cup.
Okay, like a gasket seal.
Sort of, yeah. We also have the ligament of the head of the femur, a delicate band of tissue inside the joint. Importantly, this ligament carries a small branch of the obturator artery, which provides a variable but sometimes critical contribution to the blood supply of the femoral head.
That's fascinating. A tiny ligament with the potentially life-saving blood vessel.
Mm.
What else keeps this joint so tight, so stable?
Well, the entire joint is enclosed by a strong, thick, fibrous joint capsule. And reinforcing the outside of this capsule are three powerful external ligaments with a unique spiral design: the iliofemoral, pubofemoral, and ischiofemoral ligaments. These ligaments become taut when your hip is extended, effectively screwing the joint into maximal stability during standing.
Ah, that locking mechanism again.
Precisely. This ingenious design dramatically reduces the muscular energy needed to maintain an upright position. Despite all the stability, the hip joint still allows a wide range of motion, including bending, straightening, moving your leg out to the side or across your body, and rotating it.
So what does this all mean for someone who might experience a hip injury? How does this deep understanding inform diagnosis and treatment? It's clearly not just a simple break, is it?
Absolutely not. Hip fractures, especially those involving the femoral neck, the narrower part just below the ball, are particularly problematic. This is because they can severely interrupt the delicate blood supply to the femoral head, leading to a vascular necrosis, literally, bone tissue death due to lack of blood. The blood supply to the femoral head and neck primarily comes from an arterial ring formed by branches of the medial and lateral circumflex femoral arteries, which then send small vessels along the neck. The artery of the ligament of the head provides a small variable backup.
That sounds like a big risk, especially for the elderly, maybe with weaker bones.
It is. In elderly patients, particularly those with osteoporosis, the other blood supply routes are often already diminished. A femoral neck fracture can transect the remaining vital retinacular vessels. Case 4 vividly illustrates this. A 72-year-old osteoporotic woman falls, fracturing her femoral neck. Her leg appears shorter and externally rotated due to powerful muscle spasms pulling the detached bone. Because her crucial blood supply was compromised, she required a hemiarthroplasty, where the femoral head is replaced with a metal prosthesis. This is very different from an intertrochanteric fracture, which occurs between the prominent trochanters of the femur without involving the femoral neck. These preserve the femoral neck's blood supply, allowing for simpler fixation, maybe with screws and plates. Younger patients usually sustain these fractures from high-energy trauma, while older patients with weaker bones can get them from a simple fall. This depth of understanding blood supply, fracture patterns, and patient age is what truly differentiates an expert in musculoskeletal trauma. Next, let's explore the femur, the thigh's mighty bone. It's not only the longest bone in the body, but also the primary skeletal support for the entire thigh. Its shaft exhibits a characteristic forward bow and an oblique course, which strategically positions the knee closer to the body's midline, a subtle but significant biomechanical adaptation.
It's remarkable how a bone shape can impact our entire posture and movement. But what are the key features of this essential bone, especially for muscle attachment? It must be a hub for muscles.
Oh, absolutely. Its design is full of such elegant solutions. The middle part of the femoral shaft, if you cut it across, is triangular. Its most distinctive feature is the linea aspera, a broad, roughened crest running down the posterior surface. This isn't just a rough line, it's a major and extensive site for the attachment of many powerful thigh muscles. Proximally, it diverges, sending lines for muscles like your gluteus maximus and pectineus. Distally, it widens to form the floor to popliteal fossa behind your knee. These diverging lines and attachments are critical anchors for the immense forces generated by your leg muscles. At the distal end of the femur, you have two large, rounded projections called condyle medial and lateral, which articulate with your shin bone to form the principal knee joint.
The parts that make the knee bend.
Exactly. They're separated posteriorly by a deep intercondylar fossa, and anteriorly, they join to articulate with your kneecap. The inside walls of this intercondylar fossa are crucial, bearing specific facets for the superior attachment of your crucial cruciate ligaments, the ACL and PCL, which are key stabilizers of the knee. Around these condyles are smaller bony bumps, the epicondyles, which serve as attachment points for the collateral ligaments of the knee. The femur's slight anterior bowing and its oblique course are not accidental. They are elegant biomechanical solutions that help bring our center of gravity directly over the feet, optimizing balance and reducing stress on the joints, particularly during dynamic activities.
Now for the patella, or kneecap, a tiny bone with a huge job, a sesamoid wonder. What makes it so unique and important for knee function? It just seems to sit there.
It might seem like it just sits there, but it's incredibly active biomechanically. The patella, your kneecap, is the largest sesamoid bone in the human body. It's uniquely formed within the quadriceps femoris tendon as that tendon crosses anterior to your knee joint. Its shape is triangular, with the apex pointing down, attaching to the patellar ligament, which then goes to your shin bone. Its broad base at the top is where the quadriceps tendon attaches. This seemingly simple bone is, in fact, a crucial biomechanical fulcrum. By acting as a lever, the patella dramatically improves the mechanical advantage of your quadriceps muscle, making knee extension much more efficient and powerful.
So it gives the muscle more leverage.
Exactly. Without it, everyday actions like climbing stairs or simply standing up would be significantly harder and require far more muscular effort. It's a little powerhouse. Next, we have the tibia and fibula, the two parallel bones of the leg. The tibia is the larger, medially positioned, and primary weight-bearing bone, the main shin bone. The fibula, on the other hand, is smaller, laterally positioned, and notably does not participate directly in the knee joint or bear significant weight, though it forms the crucial lateral part of the ankle joint. These two bones are interconnected along their length by a tough interosseous membrane and at their distal ends by a fibrous joint, allowing for very little movement between them.
So the tibia is the sturdy workhorse, and the fibula is more like a crucial stabilizer for the ankle. Tell us more about their intricate features, especially at the joints.
Exactly. The tibia, as the primary weight bearer, is appropriately robust and architecturally complex, especially at its ends. Its superior end features two prominent condyles, medial and lateral, which have concave articular surfaces that meet the femur and the menisci of the knee joint. Between them is the intercondylar eminence, a raised area with specific facets for the attachment of your menisci and cruciate ligaments, the ACL and PCL, which are vital for knee stability. Below the condyles, you'll find the prominent, palpable tibial tuberosity on the front of your shin, which is where your patellar ligament attaches. That's the spot for the knee jerk reflex test. The fibula's proximal end has a globe-shaped expansion called the head, which articulates with the tibia to form the superior tibiofibular joint. Just below the head is the narrow neck of the fibula.
And you mentioned this was a vulnerable spot.
Critically vulnerable. This is a clinically critical area because the common fibular nerve wraps tightly around its posterolateral aspect, making it extremely vulnerable to injury from trauma, fractures, or even tight casts. This is a detail elite professionals never overlook due to the severe functional implications of nerve damage there, namely foot drop. The distal end of the fibula expands to form the spade-shaped lateral malleolus, which creates the crucial lateral stability of the ankle joint, the bump on the outside of your ankle.
That's a lot of intricate detail. Now let's move to the ankle joint, which allows for such dynamic movement. How is it structured to handle the forces of our body while also allowing us to walk and run effectively?
The ankle joint is a true marvel of engineering, a synovial joint involving the talus of the foot and the tibia and fibula of the leg. It functions primarily as a hinge joint, allowing for the crucial movements of dorsiflexion, moving the top of the foot toward the leg, and plantar flexion, pointing the foot downward. Importantly, this joint exhibits its greatest stability when the foot is in a dorsiflexed position, a detail critical for understanding ankle mechanics and injury.
So it's strongest when you're pulling your toes up toward your shin. Why is that?
Precisely. The structure is incredibly precise. Imagine a deep, bracket-shaped socket called the mortise. This mortise is perfectly formed by the bottom of your tibia, your medial malleolus, the bump on the inside of your ankle, and the longer lateral malleolus, the bump on the outside of your ankle. Into this mortise fits the upper expanded part of the talus, a bone in your foot, like a perfectly shaped tenon. A key design feature here is that the articular surface of the talus is distinctly wider at the front than it is at the back.
Ah, okay.
As a direct consequence, when your foot is dorsiflexed, that wider anterior part of the talus moves into the joint, creating a tighter, more stable fit within the mortise. Conversely, when your foot is plantar flexed, the narrower posterior part of the talus is in the joint, making it less stable and more vulnerable.
So the way your ankle is positioned can literally mean the difference between stable movement and a painful injury. That's a serious insight. How does this translate to clinical situations like fractures and ligament tears? Ankle sprains are so common.
Precisely, and understanding this biomechanics is crucial for diagnosis and treatment. Ankle sprains often happen when the foot is plantar flexed and inverted. This joint is significantly stabilized by powerful medial and lateral ligament complexes. On the inside, you have the medial deltoid ligament, a large, exceptionally strong triangular-shaped ligament. On the outside, you have the lateral ligament complex, which is actually 3 separate ligaments. The anterior talofibular ligament, ATFL, the posterior talofibular ligament, PTFL, and the calcaneofibular ligament, CFL.
And the ATFL is the common one to injure.
By far. The ATFL is notably the most frequently injured ankle ligament. When it comes to injuries, clinicians visualize the ankle joint and its surrounding structures as a fibro-osseous ring. This conceptual framework helps predict the type of damage likely to result from specific injury mechanisms. For instance, an inversion injury, where the sole of the foot turns inward, often when the foot is plantar flexed, may simultaneously fracture the medial malleolus and tear the lateral ligaments. Case 8 provides a classic example of an ATFL tear in a long-distance runner. Stepping into a pothole caused an inversion injury in plantar flexion, placing significant strain on the lateral ligament complex. The ATFL was the first to tear, leading to persistent ankle instability. A positive anterior drawer test, showing excessive forward movement of the talus, confirmed the diagnosis, often requiring surgical repair. Fractures of the talus itself are particularly challenging. This is an unusual bone with a vulnerable blood supply, primarily entering through the tarsal sinus. Fractures of the neck of the talus frequently interrupt this crucial blood supply, leaving parts of the bone susceptible to osteonecrosis, or bone death, due to lack of blood. This can lead to premature osteoarthritis and often necessitates extensive surgery. Finally, let's explore the foot, the body's dynamic base, everything distal to the ankle joint. It's fundamentally subdivided into the tarsus, ankle bones, the metatarsus, midfoot bones, and the digits, toes. The foot serves as the body's primary point of contact with the ground, providing a stable platform for upright stance and dynamically leveraging the body forward during walking.
It's incredible how many bones and joints make up our foot. What are the specific bones and how do they all work together to achieve such dynamic function? Seems like a puzzle down there.
It truly is a marvel of engineering. There are 7 tarsal bones that form the skeletal framework of your ankle and midfoot. The 2 largest and most crucial are the talus, which sits at the top, articulating with your leg bones to form the ankle joint, and the calcaneus, your heel bone, which supports the talus and forms the bony framework of your heel. The calcaneus is where your powerful Achilles tendon attaches. Other important tarsals include the navicular, a boat-shaped bone important for arch support, the cuboid on the lateral side, and 3 small cuneiforms in the midfoot.
Okay, 7 tarsals, then the long bone.
Exactly. Beyond the tarsals, you have 5 metatarsals, numbered I to V, forming the main body of your foot. Metatarsal I, leading to your great toe, is the shortest and thickest. Each metatarsal has a head, shaft, and base. Finally, the phalanges are the bones of your toes. Each toe, except for the great toe, typically has 3 phalanges, proximal, middle, distal, while the great toe has only 2.
That's a lot of bones. How do all these small bones and their connections create movement? And what happens when those connections are compromised?
They form an incredibly dynamic system of shock absorbers and levers. The numerous joints of the foot, especially the intertarsal joints between the individual tarsal bones, primarily facilitate complex movements like inversion, turning the sole inward, and everversion, turning the sole outward. These are not just simple side-to-side movements, but complex rotations involving multiple joints, critical for adapting to uneven terrain. The subtalar joint between the talus and calcaneus is especially important for these movements. We also have the tarsometatarsal joints, which are generally quite stable, except for the great toes joint, which allows more movement. The metatarsophalangeal MTP joints are your knuckles of the toes, allowing bending and extension and limited side-to-side movement. The interphalangeal IK joints are simply hinge joints for bending your toes. This intricate system is what makes our foot so adaptable and efficient.
So, the seemingly small details of the foot's structure are paramount to its big jobs, and when things go wrong, it can be quite painful and limit everyday activities.
Yeah.
What are some of the common clinical issues seen in the foot that professionals need to diagnose accurately?
Exactly. The implications of these intricate structures are profound. One common issue is bunions, a significant deformity on the inside aspect of the first metatarsophalangeal joint at the base of your great toe. This area is critical for transmitting body weight, and abnormal stresses, often from things like high-heeled or pointed shoes, can cause a bony protuberance and crowding of the toes. Yeah, symptoms typically involve pain and inflammation, making shoe wearing difficult. Another condition, often seen at birth, is clubfoot, a congenital deformity where infants are born with one or both feet pointing inward and downward. Treatment involves gentle manipulation and serial casts to gradually straighten the foot. These conditions vividly demonstrate how deviations in the foot's sophisticated architecture can lead to significant functional impairment and pain, underscoring the importance of detailed anatomical understanding for diagnosis and effective treatment. 4. The muscular engine. Powering movement. Let's now delve into the muscular engine that powers the lower limb, starting with the gluteal region muscles. These muscles, located at your buttocks, lie posterolateral to the bony pelvis and the proximal end of the femur. Their primary actions are to move your leg out to the side, abduct, extend it backward, and rotate it laterally at the hip joint. But critically, these muscles also play a vital role in controlling the stability of your pelvis during walking, preventing a waddling motion as one leg swings forward.
So these aren't just for powerful movements like jumping or climbing, but also for that subtle balance during gait. Tell us about the different groups.
Precisely. They are crucial for both gross movement and dynamic stability. The gluteal muscles are composed mainly of two functional groups. First, the deep group consists of generally smaller muscles, primarily responsible for precise lateral rotation of your hip and abduction when your hip is bent. Think of the piriformis muscle, which connects your sacrum to your thigh bone, helping you turn your leg outwards. Problems here can sometimes even pinch your sciatic nerve, leading to pain down the leg. Other deep muscles include the obturator internus and the gemelli muscles, all working in concert to finely tune hip rotation. The second group is the superficial group, which includes larger, more powerful muscles. The gluteus medius and gluteus minimus are key for moving your leg out to the side, abduction, and crucially, they reduce pelvic drop over the opposite swinging leg during walking. If these are weak, you might see a characteristic Trendelenburg gait, a waddle. The gluteus maximus is the largest and most superficial, a truly powerful extensor of the hip think, pushing off the ground, climbing stairs, or standing up. Its upper parts also feed into the iliotibial tract, a thick band on the side of your thigh, which helps stabilize your knee. These gluteal muscles are incredibly powerful, and understanding their precise roles in gait stabilization is critical for professionals assessing movement disorders.
So these muscles are doing a lot of behind-the-scenes work to keep us moving smoothly and upright, far more than just butt muscles. Now let's move on to the thigh, where muscles are organized by compartments. How does this compartmentalization influence their function and how we approach them clinically? It seems like a key organizational principle.
Understanding these compartments is absolutely fundamental, not just for isolating muscle function, but also clinically, as it dictates how issues like swelling can rapidly become dangerous. The muscles of the thigh are distinctively separated into three compartments: anterior, medial, and posterior by layers of fascia, bones, and ligaments. Each compartment typically houses muscles with related functions and shared innervation patterns. First, the anterior compartment. These muscles are primarily responsible for extending your knee and flexing your hip. This compartment contains your quadriceps femoris muscles, a group of 4 powerful muscles, including the rectus femoris, which originates from your pelvis, and the 3 vastus muscles, lateralis, medialis, intermedius, that originate from your femur.
The big muscles on the front of the thigh.
Exactly. All 4 converge into the quadriceps tendon, which then goes over your kneecap to your shin bone via the patellar ligament. They are your primary knee extensors, allowing you to kick, stand up, and climb. Also here is the iliopsoas, a very powerful hip flexor that lifts your leg, coming down from the abdomen. Most of these muscles are innervated by the femoral nerve. The sartorius, a long strap-like muscle, also lives here, allowing you to cross your legs. Moving to the medial compartment, these muscles are mainly for adducting your thigh, meaning bringing your legs together. This compartment houses 6 muscles, including the gracilis, pectineus, and the various adductor muscles, longus, brevis, magnus. They primarily pull your thigh inward, but some also contribute to hip rotation.
The groin muscle.
Essentially, yes. Most of these are innervated by the obturator nerve. Notably, the adductor magnus is a large, deep muscle that has 2 functional parts, with one part even acting like a hamstring because it originates from the ischial tuberosity and is innervated by the sciatic nerve. Between these parts is the adductor hiatus, a crucial gap where the femoral artery and vein pass from the thigh to behind the knee. Finally, we have the posterior compartment, home to the hamstrings, which are powerful flexors of the knee and extensors of the hip. This compartment contains 3 long muscles: the biceps femoris on the lateral side, semitendinosus, and semimembranosus, both on the medial side. As a group, they are vital for bending your knee and extending your hip, think running, jumping, or climbing. The biceps femoris also laterally rotates your knee, while the semitendinosus and semimembranosus medially rotate it. All hamstrings are primarily innervated by the sciatic nerve.
Understanding these compartments is so practical. Sounds like an urgent situation if there's swelling in one, right? That pressure has nowhere to go.
Indeed, if there's significant swelling within one of these fascial compartments, it can lead to a dangerous condition known as compartment syndrome, where elevated pressure compromises blood flow and nerve function, potentially causing permanent damage. It's a true surgical emergency. Beyond that, hamstring muscle injuries are an extremely common source of pain in athletes, particularly those involved in high-power, high-speed sports. These injuries range from mild muscle strains to complete tears, often at the muscle-tendon junction. In adolescence, you might even see an avulsion of the ischial tuberosity, where the hamstring origin detaches, because the growth plate there is the weakest point. This underscores how even the strongest muscles have vulnerable points, especially during growth spurts or under extreme load. Moving distally, the leg muscles also demonstrate remarkable organization, adapting to gravity and dynamic movement. The leg, situated between the knee and ankle, is divided into 3 distinct compartments: anterior, posterior, and lateral, separated by the interosseous membrane and other fascial septa. Each compartment has specific muscle functions and innervation.
So, similar to the thigh, compartmentalization is key here too. What are the roles of each of these compartments in the leg? What actions do they control?
Exactly. The compartmental organization continues to be a central theme for function and clinical assessment. In the anterior compartment, we find the dorsiflexors, toe extensors, and inverters. These muscles primarily dorsiflex your foot, meaning they lift your foot towards your shin and extend your toes. The tibialis anterior is a powerful dorsiflexor and also dynamically supports the medial arch of your foot during walking. Other muscles here extend your big toe, extensor hallucis longus, and other toes, extensor digitorum longus. All muscles in this compartment are innervated by the deep fibular nerve. Next, the lateral compartment primarily houses the eververters. This compartment contains 2 muscles, the fibularis longus and fibularis brevis. Both muscles primarily avert your foot, turning the sole outward. The fibularis longus also contributes to plantar flexion and, significantly, helps support the lateral and transverse arches of the foot by crossing underneath it, acting like a stirrup. Both muscles are innervated by the superficial fibular nerve.
Okay, so front lifts the foot, side turns it out. What about the back? The calf muscles.
Right, the posterior compartment includes powerful plantar flexors, toe flexors, and inverters. These muscles, forming the bulk of your calf, are organized into superficial and deep groups. The superficial group includes the gastrocnemius, the 2-headed muscle you see bulging, and the soleus, a flatter muscle underneath. These together form your powerful calcaneal or Achilles tendon. These are your primary plantar flexors, pointing your foot downward, essential for pushing off when walking or running. The deep group includes the tibialis posterior, which powerfully inverts and plantar flexes your foot and dynamically supports the medial arch, and the flexor muscles for your toes, flexor digitorum longus, and big toe, flexor hallucis longus. All posterior compartment muscles are innervated by the tibial nerve. The muscles of the leg are master orchestrators of foot movement. The stirrup action formed by the tibialis anterior, tibialis posterior, and fibularis longus is a beautiful example of how antagonistic muscles work together to dynamically support the arches of the foot, which is absolutely crucial for both stable standing and efficient propulsion.
It's like a finely tuned suspension system and propulsion engine for your entire body, all working together. This must mean injuries to these critical muscles can be very serious, especially that Achilles tendon.
They absolutely can, with significant functional implications. A prime example is calcaneal, or Achilles, tendon rupture. This is often related to sudden trauma, frequently in otherwise healthy tendons, but factors like overuse or certain antibiotics can predispose. Patients typically describe a sudden, severe pain, often like being kicked or shot in the heel. They develop marked ankle swelling, a bruise, and importantly, an inability to stand on tiptoe on the affected leg. You can often feel a palpable gap in the tendon. Case 6 details such an event in a man playing squash. Diagnosis is typically straightforward and requires operative repair. This illustrates how a sudden high-force injury to a major tendon can immediately incapacitate, emphasizing the critical role of these powerful plantar flexors in everyday movement. Moving into the foot itself, we encounter the intrinsic muscles. These muscles originate and insert entirely within the foot, providing localized control and support. They primarily modify the actions of the long tendons coming from the leg and generate fine, precise movements of the toes.
So these are the micromanagers of the foot, handling the subtle movements, the fine adjustments. How are they organized within such a small space?
They are indeed the fine-tuners, essential for gripping the ground and adapting to terrain. They are organized into distinct groups based on their location. On the top, or dorsal aspect of the foot, you have small muscles that help extend your toes, like the extensor digitorum brevis. However, the plantar aspect, the sole of your foot, is much more complex, organized into 4 distinct layers, going from superficial to deep.
4 layers, wow.
Yes, it's quite packed. These layers contain muscles that abduct and flex your great toe, like abductor hallucis. Flex your other toes, flex your digitorum brevis, and adduct your toes. Deeper still, you have muscles like the quadratus plantae, which cleverly adjusts the pull of longer tendons to make toe flexion straight, and the lumbricals, which prevent your toes from hyperextending at the base and curling up, especially important when pushing off. Then the deepest layer contains the interosseous muscles, dorsal and plantar, which allow for abduction, spreading, and adduction, bringing together of your toes, crucial for gripping or spreading your toes for balance. These intrinsic foot muscles, though small and often overlooked, are mighty. They are the fine motor control of your foot, essential for gripping the ground, maintaining balance, and propelling you forward. Damage to these muscles, or their intricate innervation, can severely impact overall stability and gait, highlighting their unsung importance.
It's like having a whole orchestra playing in your foot, with each instrument contributing to the overall harmony of movement. This level of precision is truly remarkable. The lifelines, nerves and vessels.
To truly understand the lower limb, we must grasp its intricate command and sensory network. The somatic motor and general sensory innervation is precisely controlled by peripheral nerves emanating from 2 major plexuses on the posterior abdominal and pelvic walls. The lumbar plexus, formed by the anterior rami of L1 to L4 spinal nerves, and the sacral plexus, formed by L4 to S5.
This sounds like a complex wiring diagram. How do we map these nerves to specific parts of the body? How do clinicians figure out where a problem lies?
It is, and for any clinician, understanding dermatomes and myotomes is like having a detailed live-action map of the nervous system. Dermatomes are specific patches of skin predominantly innervated by a single spinal nerve level. For example, L5 sensation is typically over the top of your foot, S1 over your pinky toe and outer foot. Testing these helps pinpoint nerve root issues. Myotomes, conversely, represent groups of muscles predominantly innervated by a single spinal nerve level, tested by assessing specific joint movements. For instance, testing your hip flexion primarily assesses L1, L2, knee extension L3, L4, and ankle plantar flexion S1, S2.
So testing strength tells you about specific spinal levels.
Exactly. And in an unconscious patient, or for a quick check, tendon reflexes provide a rapid clinical test. A tap on the patellar ligament at the knee tests L3, L4, while a tap on the calcaneal tendon, Achilles, tests S1, S2. A patient's reported sensory deficit or weakness can immediately pinpoint the exact spinal nerve level or peripheral nerve involved, directly guiding diagnosis and treatment strategies. It's fundamental neurology. Diving deeper into the major nerves, those entering the lower limb include the femoral nerve, obturator nerve, and the mighty sciatic nerve. The sciatic nerve, the largest nerve in your body, typically divides into 2 major branches in your thigh, the common fibular nerve and the tibial nerve.
And where are these nerves especially vulnerable? You mentioned the fibular nerve earlier.
Critically, some nerves are particularly vulnerable due to their proximity to bone. The common fibular nerve uniquely curves laterally around the neck of the fibula when passing into the leg. In this location, where it can be rolled against the bone, it is highly susceptible to damage from impact injuries, fibular fractures, or improperly placed leg casts. Even minor trauma or prolonged pressure, say in a bedbound patient, can lead to foot drop, a debilitating condition where you can't lift the front of your foot. This detail is ingrained in every professional working in this field, as prompt diagnosis can prevent long-term disability. It's a classic high-risk spot.
It's incredible how a small anatomical detail, like a nerve wrapping around a bone,
Mhm.
can have such a profound impact on function when it's injured. What are the specific pathways of these major nerves? Where do they go and what do they control?
Let's trace these critical pathways. The femoral nerve, L2, L4, leaves the abdomen and enters the front of your thigh, supplying all muscles in the anterior compartment, like your quadriceps and skin over the front of your thigh and inner leg via its saphenous branch. The obturator nerve, L2, L4, enters the inner thigh through the obturator canal, innervating most muscles in the medial compartment that adduct your leg, as well as skin on the medial thigh. The sciatic nerve, L4, S3, as mentioned, passes through the gluteal region, usually beneath the piriformis muscle, and enters the posterior thigh. It powers all the hamstring muscles and then splits.
Into tibial and common fibular.
Right. The tibial nerve continues down the back of the leg, intersecting all the muscles in the posterior compartment of the leg. Your powerful plantar flexors and most of the intrinsic muscles of the sole of your foot, also providing sensation to your heel and sole via plantar and calcaneal branches. The common fibular nerve travels laterally, wraps around the fibular neck, and then divides. Its superficial fibular branch supplies the lateral compartment muscles, fibularis longus and brevis, and skin on the top of the foot. Its deep fibular branch supplies the anterior compartment muscles, dorsiflexors like tibialis anterior, and a small patch of skin between the first two toes.
That's an incredibly comprehensive map of nerve distribution. Given how critical these nerves are, what are the clinical implications when they're damaged and how do professionals assess such injuries? You mentioned foot drop.
This intricate network means that any damage can have widespread and specific consequences, making a neurological examination a crucial tool. It's essential for diagnosing things like nerve root lesions from a slipped disc, peripheral neuropathy, often seen in diabetes, or specific nerve palsies like the common fibular nerve palsy. The examination involves looking for muscle wasting, testing the strength of specific muscle groups like hip flexion or ankle dorsiflexion, assessing your reflexes, patellar and Achilles, and checking sensation across the dermatomes using light touch, pinprick, and vibration. A prime example of nerve injury is foot drop, which, as we discussed, is an inability to lift the front of your foot. Patients with foot drop develop a characteristic steppage gait. They have to lift their knee abnormally high during walking to prevent their foot from dragging, and then the foot slaps down.
Because they can't control the lowering?
Exactly. As we discussed, a common cause is damage to the common fibular nerve as it curves around the neck of the fibula. But it can also stem from problems higher up, like L5 nerve root compression in the spine, or even central nervous system issues. Recognizing the signs and symptoms of foot drop and determining the level of the lesion is a classic clinical skill. Now, let's turn our attention to the arteries, the blood supply network of the lower limb. The major artery supplying the entire lower limb is the femoral artery, which is a direct continuation of the external iliac artery from your abdomen. A rich network of anastomotic channels, think of them as natural detours or bypasses, throughout the lower limb ensures crucial collateral circulation, which is a built-in safety mechanism for blood flow if a main route gets blocked.
It sounds like a vital lifeline, with those anastomoses acting as backups. Can you describe the main arteries and their branches in detail? Where does the blood go?
Absolutely. The femoral artery is the primary source of blood for most of the thigh and all of the leg and foot. It enters the front of the thigh in the femoral triangle. Here it gives off smaller branches to the skin, but its largest and most significant branch is the deep artery of the thigh, or profunda femoris artery. This is the major source of blood supply to your powerful thigh muscles. It also gives off the medial and lateral circumflex femoral arteries, which are critical for the blood supply to the hip joint and form important anastomotic networks around the hip, like the cruciate anastomosis, providing vital collateral pathways, especially for the femoral head. If the main femoral artery gets blocked high up, these collaterals can sometimes maintain viability. The popliteal artery is the continuation of the femoral artery as it passes behind your knee into the popliteal fossa, going through that adductor hiatus we mentioned earlier. It's the major blood supply to your leg and foot, giving off branches around the knee, genicular arteries, and then it divides into the anterior tibial artery and the posterior tibial artery.
And those supply the leg compartments.
Precisely. The anterior tibial artery travels down the front of your leg in the anterior compartment and continues onto the top of your foot as the dorsalis pedis artery, where its pulse is clinically significant and easily felt. Checking this pulse is a key part of assessing limb circulation. The posterior tibial artery continues down the back of your leg in the posterior compartment, gives off the fibular artery to supply the lateral aspect, and enters your foot behind the medial malleolus in the tarsal tunnel, where its pulse is also palpable. In the foot, it then divides into the medial and lateral plantar arteries in the sole, which form the deep plantar arch, the primary blood supply to your toes. The body's remarkable ability to create collateral circulation through these intricate anastomotic networks is a lifesaver, especially when a major vessel is compromised. However, even partial blockages can significantly impair function.
It's like a complex roadmap of blood flow, where detours and alternative routes are built right in to keep everything running, even if there's a blockage. What are some of the critical clinical conditions related to these arteries that professionals need to be aware of?
Precisely. Chronic leg ischemia is a prime example. Its commonest symptom is intermittent claudication, a cramp-like pain that develops in your calf muscles, often indicating femoral artery issues, or buttocks, suggesting problems higher up in the aorta or iliac arteries during walking. The pain forces you to rest until it subsides, only for it to recur after a similar distance. This predictable cycle is a hallmark of insufficient blood flow. Another critical condition is a popliteal artery aneurysm, an abnormal dilation of the popliteal artery behind the knee. Unlike other aneurysms, these are more prone to embolization, where a clot lining the artery wall breaks off and travels downstream, potentially leading to severe limb ischemia and even amputation if not treated promptly. Case 7 illustrates this. A 67-year-old man with a pulsatile mass and a rumbling sound, a brute behind his knee. Ultrasound confirmed the aneurysm. Because of the high embolic risk, these usually require surgical repair. These conditions highlight the vital importance of understanding both normal anatomy and potential pathologies of these lifelines. Checking pulses and understanding circulatory patterns is absolutely fundamental. Now for the return journey. The veins. The venous system of the lower limb consists of interconnected networks of deep and superficial veins. Efficient venous return of blood towards the heart relies critically on two things: competent valves, which prevent blood from flowing backward down the leg, and the powerful muscle pump effect.
Ah, yes, the muscle pump. Explain that again.
When you walk or contract your lower limb muscles, especially your calf muscles, they squeeze the deep veins, forcing blood upwards towards the heart. The valves then slam shut to prevent the blood from falling back down when the muscles relax. It's a simple but highly effective mechanism against gravity.
That's a natural built-in pump and one-way valve system that's constantly fighting gravity. Tell us more about these different venous networks, the superficial and deep ones.
Indeed, it's a testament to the body's elegant design. The superficial veins lie just under the skin. The main ones are the great saphenous vein and the small saphenous vein. The great saphenous vein starts on the inside of your foot, runs up the entire length of your inner leg and thigh, and drains into the femoral vein near your groin through an opening called the saphenous opening. The small saphenous vein starts on the outside of your foot, runs up the back of your calf, and typically drains into the popliteal vein behind your knee. These superficial veins are connected via perforating veins to the deep veins, which generally accompany the major arteries, sharing similar names like the femoral vein and popliteal vein. The venous system is often underappreciated until it malfunctions, and the consequences can be significant.
Those consequences sound severe. What are some of the most common venous disorders that arise when this system malfunctions? Varicose veins, for instance.
Two critical venous disorders illustrate the importance of this system. First, varicose veins. This condition arises when those crucial venous valves become incompetent or leaky. Blood pools, increasing pressure on more distal valves, which may also then fail. This results in the characteristic dilated, tortuous superficial veins. It's more common in women, often aggravated by pregnancy, and can have a genetic component. Besides being unsightly, chronic venous incompetence leads to increased pressure in the small vessels, causing fluid leakage, brown skin pigmentation, venous eczema, and potentially skin breakdown and very difficult to heal ulceration, usually around the ankle. Case 3 details a young woman with large varicose veins where a tourniquet test helped identify incompetent valves, likely at the saphenofemoral junction where the great saphenous joins the femoral vein. During surgery to remove the great saphenous vein, the surgeon encountered difficulty ligating the small saphenous vein in the popliteal fossa. Tragically, this led to an iatrogenic injury, an injury caused by medical intervention to the common fibular nerve, resulting in foot drop and sensory disturbance. This highlights the critical importance of meticulous anatomical knowledge during surgical procedures, knowing exactly where nerves run relative to veins.
A stark reminder of the need for precision. What about DVT? That sounds even more serious.
It can be life-threatening. Deep vein thrombosis, DVT, involves the formation of a blood clot in the deep veins of your lower limb or pelvis. It's often caused by a combination of factors known as Virchow's triad: venous stasis, stagnant blood flow, like during long flights or bed rest, injury to the vessel wall, and hypercoagulable states, blood that clots too easily. A DVT in the calf can propagate upwards into the femoral veins. Critically, a piece of this clot, an embolus, may break off, travel through the heart, and lodge in the pulmonary arteries in the lungs, causing a potentially fatal pulmonary embolus, PE. Case 5 vividly illustrates this. A pregnant woman developed unilateral leg swelling and sharp chest pain. The pregnant uterus compressed her left external iliac veins, causing venous stasis and an extensive DVT. The chest pain was diagnosed as small pulmonary emboli. This is why DVT prevention in surgical patients and other high-risk individuals using blood thinners or compression stockings is so vital. Diagnosing DVT often involves duplex ultrasound to look for lack of blood flow in veins that don't compress. Finally, we have the lymphatics, the crucial drainage system often forgotten. This system is vital for fluid balance, returning excess fluid from tissues back to the bloodstream and also for immune function, filtering fluid through lymph nodes. Deep lymphatic vessels from the gluteal region accompany the blood vessels into the pelvic cavity, draining to internal iliac nodes. Superficial lymphatics, conversely, drain upwards toward the superficial inguinal nodes located in the front of your thigh and the groin area. Swelling, or edema, particularly if it's pitting edema, can often be a significant clinical clue pointing towards lymphatic obstruction or overload or potentially infection, lymphangitis. 6. Supporting structures, fascia, retinacula, and arches.
Beyond bones, joints, muscles, nerves, and vessels, our lower limbs have a whole array of supporting structures, like the fascia lata and the iliotibial tract. These sound like they're doing some heavy-duty work, almost like structural components.
They absolutely are. They provide crucial support and containment. The fascia lata is a remarkably thick and strong layer of deep fascia that completely surrounds your thigh, acting like a compressive stocking. It compartmentalizes the muscles. Laterally, this fascia lata is significantly thickened into a distinct, robust band known as the iliotibial tract, or IT band. This tract descends along the side of your leg from the iliac crest and attaches just below your knee on the tibia. It receives important insertions from both your tensor fasciae lati muscle anteriorly and the gluteus maximus muscle posteriorly, playing a crucial role in stabilizing the knee in extension, especially when standing. The fascia lata isn't just a passive covering, it's a dynamic structure that exerts significant pressure, aiding venous return and muscle efficiency. The iliotibial tract's tension also significantly influences the biomechanics of the hip and knee, a key consideration for conditions like IT band syndrome in runners.
That makes sense for broad stabilization. But how do we get precise control of tendons, especially around joints where they change direction? I've heard of retinacula. What are these and what's their role?
Retinacula are essential for precision and efficiency, acting like pulleys or guides. These are strong, fibrous bands that effectively strap tendons down against the underlying bone or other structures, particularly around the ankle. Their essential function is to prevent these tendons from bowstringing, that is, lifting off the bone and bowing outwards during joint movement. This maintains a mechanical advantage and ensures efficient, smooth action. We find several critical retinacula in the lower limb.
Where are these found and what exactly do they hold down? They sound important for preventing tendon issues.
A prime example is the tarsal tunnel on the inner backside of your ankle. It's a critical passageway formed by bone and covered by a tough flexor retinaculum. This tunnel transmits several vital structures into the sole of your foot. The tendons of the tibialis posterior and flexor digitorum longus, the posterior tibial artery and vein, the tibial nerve, and the tendon of the flexor hallucis longus.
Ah, Tom, Dick,
Yeah.
and very nervous Harry.
That's the one, a classic mnemonic. Additionally, the fibular peroneal retinacula, superior and inferior, bind the tendons of the fibularis longus and brevis muscles to the lateral side of the foot as they pass behind the lateral malleolus. And then you have the extensor retinacula, superior and inferior, across the front of the ankle, which strap down the tendons of the muscles that lift your foot and extend your toes, like tibialis anterior and the extensor tendons. These retinacula are like the precision guides for a complex set of cables. Without them, the tendons would lose their mechanical efficiency, bowstringing away from the joint and leading to inefficient, potentially damaging movement. Their role is absolutely critical for the smooth, powerful, and controlled action of the foot and ankle, especially in dynamic activities.
That's a perfect image, keeping all those cables running smoothly. What about the plantar aponeurosis and the fibrous sheaths of the toes? These seem specific to the sole of the foot.
These are equally vital for the foot's function and protection. The plantar aponeurosis, or plantar fascia, is a significant thickening of the deep fascia in the sole of your foot. a tough, thick band of longitudinally arranged fibers running from your heel bone forward into your toes. It not only provides crucial support for the longitudinal arch of your foot, but also acts as a protective layer for the deeper muscles, nerves, and vessels in the sole. Think of it as the bowstring of your foot's arch. Its tension is absolutely vital for transferring forces effectively during walking and running, and problems here like inflammation causing plantar fasciitis can be incredibly painful and debilitating.
Ah, plantar fasciitis. Yes, very common.
Very. Similarly, the fibrous digital sheaths are crucial tunnels that enclose the tendons of your toe flexor muscles on the plantar aspect of your digits. They are formed by fibrous arches attached to the bones and ligaments of the toes. They hold these tendons close to the bony plane, critically preventing them from bearing when your toes are flexed. Inside these sheaths, the tendons are surrounded by synovial fluid, allowing low-friction gliding. These fibrous tunnels are engineering marvels that ensure your toe flexor tendons work with maximum efficiency, allowing for powerful gripping and pushing off.
So it's not just a fancy name, it's doing some heavy lifting, quite literally, and making sure all the ropes are pulling straight. All these structures come together to form the arches of the foot, which seem fundamental to everything: shock absorption, propulsion.
Indeed, the arches are an architectural and biomechanical masterpiece. The bones of the foot aren't arranged in a single flat plane. Instead, they form flexible longitudinal, medial and lateral, and transverse arches. These arches are dynamically supported by a combination of muscles and strong ligaments, enabling them to absorb shock, adapt to uneven surfaces, and efficiently transmit forces during standing and walking. The medial longitudinal arch, your main arch, is notably higher and more dynamic, while the lateral is lower and more static. The transverse arch runs across the midfoot.
How do these arches stay up, especially under the weight of the whole body, and what makes them so dynamic and adaptable?
It's a combination of passive and active support. Passive support comes from the shape of the bones themselves and strong ligaments, like the plantar calcaneonavicular ligament, often called the spring ligament, which supports the head of the talus, the keystone of the medial arch, and the long and short plantar ligaments. These ligaments act like tie beams, preventing the arches from flattening under weight. The plantar aponeurosis also provides significant passive support, but equally important, perhaps more so for dynamic function, is dynamic support from muscles. The most critical dynamic supporters are the tibialis anterior, tibialis posterior, and fibularis longus muscles. Their tendons cross the foot in a way that creates a stirrup effect, actively pulling up and maintaining the arches during movement. Intrinsic foot muscles also play a role. This dynamic support from muscles constantly adjusting to terrain and load is as important as the static support from ligaments. This incredible adaptability is what makes our gait so efficient and protects our joints further up the chain from impact forces.
It's like a finely tuned suspension system for our entire body, allowing us to traverse all sorts of surfaces without jarring ourselves to pieces. Amazing complexity. 7. Bring it all together. Surface anatomy and clinical insights. Now let's put on our professional hats and see how this deep, interconnected knowledge of the lower limb applies in real-life clinical scenarios, just like the experts do every single day. These cases bring all the anatomical and physiological details to life. But first, let's consider how we locate key structures with a hands-on approach. For any medical professional, and even just for your own understanding, palpating and identifying key tendons, muscles, and bony landmarks in the lower limb is essential for precisely locating major arteries, veins, and nerves, right?
Absolutely. That ability to read the body's surface is foundational. It's where physical examination begins. In the gluteal region, you can easily feel your iliac crest at the top of your hip. Below that, on the lateral side of your hip, is the prominent, hard, greater trochanter of the femur. And when you sit, you're often sitting directly on your ischial tuberosity. Knowing these landmarks is critical for safe intramuscular injections in the gluteal region, always aiming for the anterior part of the upper lateral quadrant to avoid the underlying sciatic nerve and major vessels. Precision matters immensely here. Moving to the femoral triangle in your upper thigh, its boundaries are the inguinal ligament superiorly, the sartorius muscle laterally, and the adductor longus muscle medially. Here, you can easily feel the femoral artery pulse just inferior to the midpoint of the inguinal ligament.
Midway between the pubic bone and the hip point.
Roughly, yes, between the pubic symphysis and the anterior superior iliac spine. And remember, the order of contents from lateral to medial. Nerve, artery, vein, empty space, femoral canal with lymphatics, navel is a common mnemonic. This area is a common site for rapid arterial or venous access in clinical emergencies due to its accessibility. Around the knee joint, your patella or kneecap is obvious. Above it, you can feel the thick quadriceps tendon, and below it, the strong patellar ligament connecting it to the tibial tuberosity. A quick tap on that ligament triggers your knee-jerk reflex, testing spinal levels L3 and L4. On the lateral side of your knee, you can feel the head of the fibula, and just below that, you can often feel the cord-like common fibular nerve wrapping around the fibular neck, that very vulnerable spot we keep mentioning. The iliotibial tract is also palpable laterally, especially when the knee is extended. Behind the knee, in the popliteal fossa, the diamond-shaped space, the popliteal artery pulse is deep and harder to find, as the artery is the deepest structure there, right against the bone. But it can usually be detected with firm palpation just medial to the midline. Down at the ankle and foot, the medial malleolus and the calcaneus heel bone form essential boundaries for locating the tarsal tunnel on the medial side. Behind the medial malleolus, you can feel the posterior tibial artery pulse and often locate the tibial nerve. Remember Tom, Dick, and a very nervous Harry for the order of structures passing through. The strong calcaneal Achilles tendon is easily palpable as it descends to your heel, and tapping it tests your S1, S2 spinal levels, ankle jerk reflex. On the top of your foot, between the tendons of your big toe and second toe extensors, you can usually feel the clinically significant dorsalis pedis artery pulse. For any healthcare professional, mastering surface anatomy is absolutely non-negotiable. It's the first and most fundamental step in physical examination, allowing for rapid assessment and precise localization of potential problems, like a diminished pulse indicating vascular compromise or tenderness along a nerve suggesting impingement. It's the language of hands-on diagnosis before you even reach for imaging.
It's like learning to read the body's roadmap in real time, offering immediate, tangible clues to what's going on beneath the surface without even needing fancy equipment yet. This is where it all comes together. Let's dive into some of those real-world case studies to see how all this elite knowledge is applied.
Yes, these diverse cases truly highlight that mastering anatomy isn't just about memorizing names. It's about understanding the why behind injuries, the precise mechanisms, the complex interplay of structures, the underlying risk factors, and how different systems interact. This depth of interconnected knowledge is what truly differentiates an elite professional, allowing for accurate diagnosis and effective treatment. Let's start with case 1, knee joint injury, the unhappy triad in skiing. Imagine a young man on the slopes whose right knee is forced into external rotation and a valgus position, meaning bowed inwards relative to the thigh. This twisting and outward force mechanism caused a cascade of damage. His anterior cruciate ligament, ACL, resisting the forward movement and rotation, became taut and snapped. His tibial collateral ligament, TCL, on the inside of the knee was stretched and torn by the valgus force, and his medial meniscus, which is attached to the TCL, was also torn, often getting pinched in the process. This classic combination, ACL, TCL, and medial meniscus tear, is famously called the unhappy triad.
Unhappy indeed.
Very. He experienced immediate tremendous pain and significant swelling hours later because the richly supplied ACL bleeds heavily into the joint when it ruptures, irritating the synovial membrane. Treatment required surgical reconstruction of the ACL, often using parts of the patient's own patellar ligament or hamstrings as a graft, potentially repair or healing of the tibial collateral ligament, and arthroscopic cleanup or repair of the torn medial meniscus to prevent locking and further damage. Understanding the biomechanics of the injury mechanism is key here. Next, case 2. Osteomyelitis diabetic foot ulcer. A 45-year-old man with diabetes developed a non-healing ulcer on his heel, a common pressure point. Diabetes is a double threat here. It causes both peripheral vascular disease, narrowing arteries and impairing healing due to poor blood supply, and peripheral neuropathy, which reduces sensation, meaning minor injuries like pressure sores go unnoticed until they are severe.
So he couldn't feel it, and it couldn't heal properly.
Exactly, a dangerous combination. The ulcer became infected, with pus visible at its base. X-rays and MRI confirmed osteomyelitis, an infection invading and destroying his calcaneus, heel bone. This required aggressive treatment, surgical washout and debridement, removal of dead and infected bone, followed by long-term, often intravenous, antibiotic treatment. Preventing these ulcers through proper foot care and blood sugar control is paramount in diabetic patients. Then, case 5, deep vein thrombosis pregnancy and pulmonary emboly. A 28-year-old woman, 36 weeks pregnant, presented with unilateral left leg swelling and sharp chest pain. Pregnancy itself is a major risk factor for DVT due to hormonal changes affecting clotting and, importantly, venous stasis. Her large uterus was compressing the left external iliac veins against the pelvic brim, slowing blood return from that leg, part of Virchow's triad.
So the baby was physically blocking the vein.
Effectively, yes, increasing the risk. Duplex ultrasound confirmed extensive left-sided DVT in the femoral, popliteal, and tibial veins, showing no blood flow and non-compressibility of the veins. The sharp chest pain was diagnosed as small pulmonary emboli clots that broke off from the leg DVT and traveled to her lungs, a potentially fatal complication. Anticoagulation therapy was immediately instituted to prevent further clot formation and embolization. Finally, Case 8, anterior talofibular ligament tear ankle instability. A young long-distance runner developed acute swelling around her lateral ankle after accidentally stepping into a pothole. This caused a sudden inversion injury with her foot likely in some degree of plantar flexion, significantly straining her lateral ligament complex. The anterior talofibular ligament, ATFL, is typically the first and weakest ligament to be disrupted in such scenarios. Initially diagnosed as a simple sprain, she later experienced persistent ankle instability. Her ankle kept giving way, especially on uneven ground. Clinical examination revealed a positive anterior drawer test of the ankle, indicating excessive anterior translation of the talus on the tibia compared to the uninjured side, and potentially increased talar tilt. MRI confirmed a complete tear of the anterior talofibular ligament. Due to the persistent instability impacting her running, surgical repair was necessary to restore ankle stability. This shows how understanding ligament function and stability testing is crucial beyond the acute injury phase.
Wow. We've truly taken a deep dive today into the incredible world of the lower limb. From its foundational anchors to its intricate web of bones, joints, muscles, nerves, and vessels, we've explored how this masterpiece of biomechanics supports, propels, and senses. We've even looked at how an elite professional would diagnose and treat complex injuries, connecting all those anatomical dots.
It's a system where every detail matters, from the largest bone to the smallest nerve branch.
Hopefully, you now have a much richer appreciation for every single step you take, every move you make, and the remarkable complexity that powers your daily life. Your lower limbs are doing so much more than you ever imagined.
They really are working hard for you, constantly.
Next time you stand, walk, or run, maybe just take a moment to consider the silent, intricate dance happening within your lower limbs. Think about how a tiny twist, an unexpected impact, or even a systemic condition like diabetes can disrupt this perfect symphony. How does truly understanding this complex, adaptable system change your perception of simple, everyday movements? And what new questions does it provoke about the body's resilience and its profound vulnerabilities?
That's a great point. Understanding the how deepens the appreciation for the what.
Keep observing, keep learning, and perhaps keep asking why. Your body is an endless source of fascination, and there's always more to uncover. Join us next time on The Deep Dive.